Again, Angela, thanks. Oh, there we go. Thanks very much for allowing me the opportunity to share some of the things that we're doing to help adapt to what we're hearing in the market. I do want to keep this casual. I just want to again go through a couple of slides of what we've done most recently. One of the things that we have had, come up just really within the last couple of years is a really heavy focus on behavioral health. And also the call for standardization and simplification from a design standpoint, from a post-occupancy user standpoint. So what we did last year is we actually developed what is now patent pending a new rail system. And this is for the very first time. It is a universal rail. There are basically two fundamental styles of rail that are in the marketplace. If you use an Amoco or a modular head wall or rail system, that's one type. And then if you use ours and old legacy Hill-Rom out there, that's the old Fairfield style, that's another type. But what there hasn't been is the ability to blend those two kinds of adapters and styles of mounting together in one product. And what we did last year is we put our heads together and figured out that yes, we actually can do that. We've been able to create what we call our One Rail, which is a universal rail. I understand from the folks at Healthcare Design, we're actually a finalist in the Product Innovation Awards this year, which will come out in May. I can't say much more to that, but so we've been able to marry, if you will, the 100% of the world of rail into one rail that allows you to be able to flex and adapt and change and bring things in differently. What is innovative and unique about it is that this is kind of if you were to bring an iPhone and a Samsung phone or something, together in one product that was able to, be compatible with iPhones and be compatible with a non-Apple product, all in the same product. I mean, it's kind of the healthcare equivalent of doing that. I mean, the two are radically different, but for the first time are being able to use together. And how this impacts the quality of care is really the end result, right? We were able to now look at how we can manage the stuff, the patient care tools, and in those environments universally. So it's not, oh, we can't use this here because we have legacy modular head walls, or we have legacy Amoco, or we only have this, or we only have that. It kind of eliminated the whole barrier to being able to go forward and managing equipment management systems as a whole. And what we've driven this to the behavioral health side is, the data that is out there. This is just out a couple of weeks ago in Becker's Healthcare. There's just been this huge surge in assaulting and problems, anger and violence, towards nursing. ENA just did a survey of 500 members, of which 56% responded that they had been physically or verbally assaulted and faced threats of violence just within the 30 days prior to that interview. And 10% were considering leaving the workforce because of that. So, I mean, we're already facing a nursing shortage. The last thing we need is more nurses leaving the bedside. Most of you know that I also come from a clinical environment, from the ER primarily. And I know that environment is rough, and it's getting worse. I mean, there's always been issues, but now we have even more and more of that. So how does this new product that we develop contribute to the quality of care? Well, most EDs are set up pretty much the same, right? You've got a sidewall, you've got your PPE, you've got certain supplies and other things there. Then you have a head wall. And in this particular case, this is the 24-bed freestanding ER is part of a very large system here in Central Florida. And most freestanding ERs don't have behavioral health rooms designed because, they're just passing patients through or holding or then transporting out if they're more critical. But, there's very few that actually have a dedicated behavioral health room. So what we've done is we've been able to now take all of the devices that are there in a typical patient room, and it really doesn't matter if it's ER or can be anywhere for that matter, right? But even with the different styles of rail, in one case we have the modular accessories, and then we have the R rail on the other side, right? We are now able to strip that room down and manage those things, and I'll show you in a second how we do that, right? But now we've basically de-weaponized the room. You can no longer weaponize an ophthalmoscope. You can't weaponize a sharps container or something else that's in there. So We haven't made it ligature proof. We're not pretending that it is a true, ligature health or ligature proof environment. We're creating a less stressful environment for the patient because there's less clutter, and we're making it a safer environment for the clinicians because you can't take a pillow speaker cord and use it to strangle yourself or somebody. So we've really made it a low risk by de-weaponizing these things. And what we've done, and here we've applied this universal rail onto our cart, we can now manage accessories from any head wall, from any style, from any brand on that one rail, on that cart, and then consolidate all that outside the room. So we're still providing somewhat accessible to the PPE, to the sharps, to those kinds of things, but we've taken it out of the room and we're managing now in that environment. So again, just making it a lot easier to adapt that space to that behavioral health environment. Another example, this is a 26-bed ED up in the Atlanta area, tied to a university medical center. They renovated all 26 beds with the sole intent of putting everything in those rooms on a rail. And being able to take and they had literally, 7 or 8 behavioral health patients in a 26-bed ER. They happen to serve an environment that is probably a little more high density for that population. But the whole idea was to be able to then take anything that's on the wall off the wall. And what they're doing is they're actually doing multiple beds on their cart. So they've held up to 4 beds of content worth of stuff on their cart. And again, it's safe. They're not losing it. They're not breaking it. It's something that they can manage. They can find it and then put it back when the room becomes viable for just a standard, if you will, non-behavioral health patient. But again, we're creating these safe rooms or these behavioral health light rooms, if you will, on demand, and not by design of the architect. So it's something that post-occupancy, any environment can be turned into this. And it's something that they can renovate very quickly if they want to adapt or ramp up to that. The other byproduct of having those carts in the room is that we're also talking about, the management of surge populations. If you look at the why of most owners these days, is they want to be able to manage through surge, whatever the surge is. Most people forget that, they always think about the big incidents that you hear on TV and the earthquakes and the hurricanes and everything else. But the reality is that if you got a school bus driving through your neighborhood, you have a risk for a mass casualty incident, and it can be anywhere at any time. So really every hospital needs to have that mindset of their hazard vulnerability assessment and what they can do. Having one of those carts available for their surge or for their behavioral health also allows them to help manage that in non-traditional spaces, alternate care locations, whether it's outside the ER, whether it's at a hallway, whether it's in a tent that you would put up. You can bring with a single element of that cart all of the requirements that you would need at the bedside in those spaces. And keep in mind that every ER pretty much overflows every day in the United States. Hallway patients are just a routine. The picture on the right is University of Chicago. 32 designated hallway patients. There's nothing there, no PPE, no devices for care. There's nothing. It's a compromise at every level. And the picture on the left is a hospital down here in Tampa. The Super Bowl was down there several years ago, and through a grant, they were able to purchase 9 of these carts that they were able to deploy literally anywhere on the grounds of the healthcare facility in order to manage the potential and risk for surge. And they've done that since then on a number of other occasions, and also now for the behavioral health type. So these are just some of the value propositions that the One Rail provides on the cart for flexibility, for behavioral health, and also a side benefit of being able to deliver the essential services to those alternate care sites that may come up because of surge populations, even unrelated to behavioral health. So in summary, there's really no area where it cannot be used. It is technically the lowest technology device in healthcare. I mean, it's the easiest thing in the world. It's a rail and an adapter. It doesn't, get any easier than that. So it's a simple post-occupancy in-service. It's a very easy install application, but we believe from the installations and the deployments that we've done so far, it really has a strong clinical value in the environment that we're serving in the ED right now. So it pretty much ends the death by PowerPoint here today. So, but if you don't have my contact, it's on there. It's Now, very interested in getting your thoughts and feedback on this. Anybody still there?
Yeah, we're here. Yeah, if everyone, I know not everyone can, but feel free to turn your cameras on. It's just discussion now. So if anyone has feedback or
Yeah.
any other conversation about behavioral health environments that they'd like to contribute, please do.
I mean, what are y'all seeing out there for behavioral health, and what are the solutions that your clients are asking for? I mean, I think that's one of the things that, you know, are we on the right track? Does this make sense? What are you hearing and seeing?
Hi, Gary, Jenny Becker.
Hi.
We are um, we are on the pillow speaker side, so we're on the cable cord side of things. So we're asked all the time for products that can assist with patient control, but taking the cords away. And we know too, it's a huge challenge to be able to give the patients what they need, but without any cords or anything that could be a ligature. So we are, it's an area we're continuing to develop more and think through more. I thought this was a unique product. With being able to move things outside and make things portable. We are hearing from our hospital customers that the influx of behavioral health patients is putting a strain on the facilities because they don't necessarily have the right equipment or the right environment. So I don't have much feedback for you, but glad to see that there's things out here that are helping along this line.
I appreciate that, Jenny. Thank you.
Hi, Gary. This is Shirley Sarbaugh. I
Hi,
work
Shirley.
at an architecture firm, and we do a lot of behavioral health. I don't specifically do a lot of behavioral health, but I do know that most of our designs still have the gate that comes down to accommodate behavioral patients in, say, an ED. We haven't really gone. I think this product is great. It has opportunities, I think, but we obviously haven't seen that in our practice yet. And I guess my only concern would be storage. Like, where are we going to put all these carts when we don't need them? Because the storage always seems to be the places that go first, to accommodate patient care. So.
Yeah, I understand, and we've heard that as well. I mean, and sometimes they're used as, if they'll have a work surface on it, they can actually be used as a workstation when they're not applied to the behavioral health side. And as far as your garage doors, I mean, I get it, and the challenge right now in the emergency departments is that not every room has a garage door to hide the services, but you may have 2 or 3 dedicated to that end, but if you have 3 behavioral health patients in those rooms, but now you have 7 or 8 patients, a couple more that are Baker acted, and that's the problem that hospitals are seeing, is that you may have dedicated rooms for behavioral health, but the population is exceeding the rooms that you have. So what do you do in those other rooms? And what we've done here on several applications and deployments is that you can literally now turn any room that doesn't have a garage door into a much less threatening room for both staff and a less stressful room for the patient by doing this. And that's the problem, right? You have 2 dedicated garage door behavioral health rooms, psych rooms, if you will, we used to call them, but you get 7 patients, right? That's the issue.
And that's a great point. I mean, when we're building new inpatient facilities, I mean, we're starting to look at how we can make even the floors have behavioral health type settings, so.
Yeah.
It's starting to be a conversation across the board.
And we're finding that pretty much everywhere. And that's, what we're trying to do is something that's a relatively quick fix that they can apply now until something more concrete and something, through a renovation or something. These are things that can be applied very quickly to solve an immediate problem. We have a project down here in Orlando. It's a 51-bed ED that, you know, they've basically come to us and said, look, put rail in every one of these rooms and let us take this stuff down when we need to, because, you know, people have tried to take ophthalmoscopes off the wall, and they take the cables and try to, you know, do bad things to themselves, and they just want to be able to get the stuff out on demand. And, you know, they also see a very high percentage of their patients, you know, and they only have 2 dedicated behavioral health rooms, but, you know, they routinely keep 7, 8, 9 patients in there. So, and they've had problems, and that's what, you know, hopefully the solution, is at least something, an interim that they can use until they get something better.
And that's every.
Hey, my name is Adrienne Morris. My background is pediatric ER, and I've definitely used the garage doors before, and those are super nice and an easy solution, but they're not in all EDs, just as you mentioned. And I do like the rail solution since it's easy to install, probably lower cost than placing the garage door in. But when I was at the bedside, there's so many patients that all of a sudden they're critical. So you need all that supplies in there, but all of a sudden they go 1-to-1, and or you find that out that they're on suicide precautions, behavioral precautions, what have you, or get agitated, things like that. The issue with a lot of just the supplies in general is when you do take it off, where do you store it? Because then things go missing, or like you're shoving it in a cabinet in the room, then you have to lock the cabinet, make sure there's, you know, a key available that the nursing staff or whoever has the key in case you do need to use it. It's like, it's very interesting, but I feel as though I foresee in the future that the majority of rooms in ED, specifically the pediatric world, have to be outfitted to meet both. Because it is frustrating when all of a sudden, okay, let's say it's flu season, and you are getting an influx of breathers in the ED, and there's just a low census of behavioral health patients. You're having to put kids in those behavioral health rooms that are very, very specifically designed for that behavioral health room. It's kind of frustrating. So it's like a catch-22. Sorry, that's a long answer, but it'll be interesting to see. I think you're right with the flexibility of these rooms, that every room has to be adaptable and easily within less than 5 minutes. You can change it to a behavioral health room.
And what they found, and again, the freestanding EDs that we've worked out down here, you know, they don't have any behavioral health rooms, but what's nice is that once they download everything from the wall onto the cart's right outside the room. So for some reason the patient crashes, all you do is bring the cart back in, and you can work off of everything that's on the cart. So,
that's,
you know,
great.
It becomes more or less like a mobile crash cart, if you will. It's got everything you'd have in the room. It's all still there. So you don't have to go very far, but I understand exactly what you're saying. You know, patient acuity will change. How do you accommodate that? Well, the cart's literally right outside the door.
That's perfect. Yeah, I really like it. All great ideas and great products. Thank you.
Yep, thank you. Anybody else have any thoughts? I mean, does this make sense, or is that from a clinical standpoint, user standpoint, architectural design standpoint?
Hi, Gary. It's Chris. How are you?
Oh, good. Chris, how are you?
Yeah, you know, I'm a fan. I love the rail system. The fact that you now have this universal thing is amazing. But here's a question. Like anything that's got like a track in it, it can get dirty. So is it easy to clean? Do you give instructions on how to clean it? Are there certain products you should use to clean it? I mean, does it get gross in the track in there after months and years?
Well, I mean, it shouldn't, but again, what we've done is we've more or less just emulated that which has been out there in other products, the other Headwall brands, for many, many, many years. So, you know, the groove in the rail is not something new. We've just now kind of merged that with our standard Fairfield rail. Feather duster, easy clean with wipes. You can get in there. You can easily. It's not too small to to get a cloth in there. It's like anything else. It just has to be cleaned. I mean, how many tops of computer cabinets get cleaned realistically? I mean, there's a lot of other places in the ED room that'll get a lot dirtier than the rail will. But to answer your question, yes, it's very easily cleanable. I've actually had hospitals take them out. We had a hospital in Seattle. They actually use these carts as movable power columns in the critical care areas. And they would literally rotate them through every couple months in the back loading dock and pressure wash them.
Yeah.
And then bring them back
Or put 'em
upstairs
through
to
the
ICU.
The equipment washer, yeah.
Yeah. So
So Jamie, Gary, I don't know if you saw, there's a question in the comments, from Jamie. How wide is the cart? And although it is on wheels, will we have to consider the width of the hallway for joint commission, et cetera?
the cart's about 18 inches front to back and 24 inches wide. The rail hangs over the side. So as far as it's not going to take any, if it's up against the wall, it's not going to take up any more space into the hallway than your standard computer cart or crash cart. It's actually got a lower footprint than a crash cart would. So probably don't need to have any additional commentary or consideration from a joint commission standpoint.
She said, great.
Yeah. And the wheels are very rugged. I mean, you can go over thresholds, you can go over elevators, you can go outside, you can run it. I mean, I've deployed it in with our DMAT team, in field hospital deployments where, it'll run over grass, it'll go into the parking lot, it'll go in the parking garage. I mean, so, you can literally take this thing anywhere and use it for any purpose, and from a surge overflow standpoint as well. So it kind of gives you flexibility from an ER management standpoint that really nothing else to date has given you as an ER manager. It just gives you more options than anything else that's been out there.
I'm sorry if you said this already, but are you going, I know you usually, when you exhibit at conferences, you have your rails, but will you have a cart at any shows coming up?
We use these carts both at the Critical Care Nurses Show, which is coming up in May. We work with another company called Teleflex, where these carts are being used as part of their simulation competitions, and we also do that with the Emergency Nurses Association. We don't bring them to PDC because the folks there really don't have an appreciation, quite frankly, for what it is. We have documentation and flyers and presentations on it, but unless you have a clinical background or understand the real clinical need, it's very hard to an architect or a designer to, I think, fully grasp the value on just seeing it. It looks big and clunky, and so we've had it at shows before and really didn't get a whole lot out of it. But we do, like I said, at the clinical shows, we'll be there. So, and of course, I've got your flyers to hand out at those shows too. So
yes, thank you.
Yeah. And we can do mock-ups and demos. I mean, we have put them up and let people try them. So if anybody's interested in actually seeing one and working with it, we can put one out to in the field. Like I said, we have multiples, deployed and in place already. So we've got user references. I've got nurse managers, on speed dial that would gladly testify to the value that they've seen with the application. So it's been proven in use, for almost 6-8. Well, the rail came out last year, so yeah, 6-8 months now. So we have evidence-based information.
Yeah, that's great. Okay. Any
All
other
right.
questions, comments? I'm going to post this recording in our community forum. And so the board and myself are really trying to encourage our members to use that more. And I've seen a lot more activity on it in the last month or so. So thank you to those who contribute to it. We're going to post this there and just continue the conversation for those that couldn't make it today. So feel free to chime in on that forum on our website. If you have any other comments or ideas, that's where the conversation will continue.
And feel free to reach out to me directly. See my contact information there, and you know, we're always available for questions and feedback. I mean, you know, we build our business because of we listen to the field, and this is the feedback we're getting. So, and no is never the answer. So, you know, whatever information or thoughts you might have that we can be better at what we're doing, please, you know, chime in and let us know.
Awesome.
Thank you.
Thanks,
everyone,
Gary.
for joining.
All right.
Yeah, thanks, Gary.
Thanks.
Take care, everybody. Have a safe
Thank-
weekend.
Thanks.
you.